Good evening, everyone. I welcome you again and another interesting meeting of 4D, that is detailed discussions in diabetes and its complications. Today we have a very interesting topic. Today we'll be talking about weight. I believe one thing that is the center of every dinner conversation, I believe nowadays. That's why we see a lot of Facebook videos, lots of WhatsApp videos on health influencers trying to tell how you can lose weight. But how does this weight affect our metabolic system? How it affects our chances of developing diabetes? How it affects chances of developing PCO in girls? All this will be discussing today, and we have very senior speaker today with us for this meeting. Uh, I'd like you all to welcome Dr. Varun Prasanna. Dr. Varun is MBBS from Chidambaram, and he did his MD in general medicine again from Chidambaram. Then he did his diploma in management of hypertension and clinical endocrinology and diabetes in 2018. He also did his PG diploma in cardiology in 2018. Uh, he's currently working as vice chairman at Prabhu Diabetes Specialty Center in Trichy, and he has a vast experience in management of metabolic problems, and he's trained in patient management and ICU management, and he is life member of various medical associations as well, and he has multiple publications to his credit. So I welcome Dr. Varun, and will like to hear from you about diabetes and obesity. What is the link? How these are linked, and what how it leads to CV disease? Over to you, Doctor.
Good evening, all. Thank you, Dr. Atul sir, for the brief introduction. And as you said, obesity being the cornerstone or be the center part of creating what not all cause all sorts of comorbid conditions in our population. To start from tier 1 city to tier 3 villages, rural, everywhere, this obesity has been playing a very major drastic role in bringing up the levels of comorbid conditions as well as the mortality and the recovery of these patients also. And it's quite interesting when I went through the slides and when I had to prepare for this talk regarding the obesity, the various hormonal changes happening, the behavioral changes happening, the adiponectins, insulin resistance, hypertension, renal issues, cardiac issues, so many things where the center point is being obesity, which is causing all these kind of problems. So with this introduction, so let me go with my slides on. So body weight being a risk factor for diabetes and cardiovascular disease, not only cardiovascular disease, but diabetes, cardiovascular disease, and many other comorbid conditions, as I said, including the psychological part of the patients also. So obesity in India, see, obesity has now become a pandemic, like how COVID was, and how diabetes has also been called as an endemic and a pandemic, and it's been spreading throughout. Initial previous years, we had seen this obesity only in high socioeconomic status people or tier 1 cities. But nowadays, because of various aspects, obesity has been pulled down even to tier 2 and tier 3 cities, and then even in low socioeconomic status due to various food habits changes and various socioeconomic status and all. So obesity is a complex condition of increased subcutaneous and visceral adiposity. So these are the two important parts grossly in obesity, where the distribution of fat in obese people matters a lot in creating the comorbid conditions. So this subcutaneous adiposity and the visceral obesity, when they are distributed in the different ways in different population, and how hazardous they are with respect to the distribution of the fat in obesity matters a lot in creating these kind of problems in comorbid conditions. So it is associated with adipose dysfunction and insulin resistance, which increases the risk of diabetes and cardiovascular disease. In our India, almost 3 out of 4 Indians are overweight. So which means not only obese, overweight also starts creating these kind of problems because of this leptin and ghrelin hormone, and because of this insulin resistance, causing a lot of endothelial dysfunctions, intima media thickness dysfunctions, creating a lot of comorbid conditions. So overweight also has to be addressed, not only the obese or morbid obese patients. The prevalence of abdominal obesity was found to be 40% in women and 12% in men. Especially this happens a lot in the postmenopausal people, women. So that has to be taken into consideration. Studies show that 5 to 6 out of 10 women between the ages of 30 to 49 are abdominally obese. The association of abdominal obesity in women is stronger with older age groups, urban residents, wealthier sections, and non-vegetarian. So there has been a lot of distribution of this obesity across the country, especially in a place like India, where there has been always a diversity of the culture, the diversity of the food habits, their eating in the morning times and night times. People nowadays in IT working more in the night times, eating a lot in the night times when they are into the night duties, when they work for the multinational companies abroad. So a lot of changes in the circadian rhythms and the food habits, everything, and a diverse population in India matters a lot in bringing down these kind of conditions. So Indians are at increased biological risk for cardiovascular disease. So there is a term that in India, even though the BMI is low, they are considered to be obese. So we call them thin fat Indian. People might have low BMI, but they are considered to be fat because of various phenotypic distribution. The Indian, South Asians and Indian phenotypes are vastly different, where they start getting this insulin resistance and comorbid conditions at a lower BMI level itself compared to the blacks and Caucasians. So Indians are known to have the highest cardiovascular or cardio-coronary artery disease rates. The prevalence of CAD in Indians living in India is 21% for diabetics and 11% for non-diabetics. The prevalence of CAD in rural parts of country is nearly half than that in urban population, and this clearly gives us the clue of that diverse lifestyle modification, lifestyle habits, and these psychological habits where they are completely different in a rural and an urban population. We would say that in urban population it is going significantly going up, whereas in rural population it started becoming very heavy also. So which means both are not spared, but urban population are having higher prevalence of CAD than the diabetes in India. In India, around 77 million people above the age of 18 years are suffering from type 2 diabetes. So this is very alarming, because with the growing population status of India, when people above 18 years are becoming type 2 diabetic because of insulin resistance, because of obesity, then we are at the alarming stage that in the future the expenses due to medicine and hospitalization is going to go very high, and people might have a deleterious effect in their economics. Nearly 25 million are pre-diabetics. Adults with diabetes have a 2 to 3 fold increased risk of heart attacks and strokes compared to people without diabetics. So all these things, all these data are quite alarming, and we have to understand and make our patients and our population to also understand by giving public awareness or awareness talks, stating that the baseline of these kind of problems is obesity, and that has to be properly addressed. So linking obesity, diabetes, and cardiovascular disease. So American Diabetics Association, they have studied almost 4 lakh people, where they studied people without diabetes and with diabetes with respect to various factors. So various factors they included, the left ventricle ejection fraction level, the mean carotid intima media thickness level, the pulsive arterial stiffness, and the coronary cardiac index, cardiac output index, cardiac contractility index. So with respect to all these, they found out that people who are diabetic or non-diabetic, but people who are obese, had overweight and obese, had a deleterious effects even though patients were non-diabetic. So which means obesity carries more problem than people who are diabetes and non-diabetic. So this way we have to understand that addressing obesity is very, very important. So the obesity, diabetes, and CVD mechanisms are various. They start from the defective translation pathway, where insulin resistance plays a major role, lipotoxicity plays a major role, inflammatory process they play a major role, accumulation of lipid derivatives in the abnormal spaces, impaired oxidative capacities. So there are so many pathways starting from inflammation to lipid toxicity, insulin resistance, and all these things bringing down the quality of the protein synthesis, and finally going into a comorbid conditions. And this is the major link between this obesity, insulin resistance, and cardiovascular disease. So when we talk about insulin resistance per se, there is a hyperinsulinemia state initially causing increased MAP kinase activation and leading to the accelerated atherosclerosis. And the other pathway is it has an impaired P-terine kinase signaling, impaired muscle glucose uptake, and impaired suppression of glucose production, finally development of type 2 diabetes mellitus. So insulin resistance individually has a tendency to cause accelerated atherosclerosis even before becoming diabetic. So patients who are in insulin resistance stage itself, they suffer these kind of comorbid conditions even before becoming diabetic. So this part is purely related with obesity alone, because there is no hyperglycemia to cause this thing. Just obesity causes this thing because of insulin resistance. So how do we prevent? So we knew that, now we understand that obesity causes all kind of comorbid conditions, and prevention is the only way where we can do this without spending anything. Where we need not spend any money, we need not do anything. Just prevention of this obesity will help in bringing down all these kind of conditions, and we can expect a very good quality of life and quality of mental peace also during the longevity of the patients. So regarding obesity, you have to limit the unhealthy food, increase physical activity, limit the television time, screen time, or the mobile time, or the reels time, improve sleep, and reduce stress. Regarding type 2 diabetes, we all know lifestyle modification is the cornerstone for everything. Reach and keep a healthy body weight. Stay physically active with at least 30 minutes of moderate exercise every day. Eat healthy diet, avoid sugar and saturated fat, and avoid tobacco smoking. For a cardiovascular disease expected patient or cardiovascular disease patient, eat a healthy diet, as already said, physical activity, stop your smoking, and this self-monitoring, or at least periodical monitoring of the blood pressures, lipids, and sugars are very, very important to reduce the risk of a re-problem of the cardiovascular disease, or re-attack, or a heart failure. So self-monitoring should also be emphasized. Self-monitoring of the weight, self-monitoring of the sugars, self-monitoring of the blood pressures, and the lipids should be very, very, very much emphasized in our patients in order to prevent the deleterious effect of cardiovascular disease. So this is regarding prevention, and next will be the regarding of therapeutic strategies, what all are available next. So once we get into this spread, our main aim first should be definitely to reduce weight, because without reducing weight, if you go in for any kind of strict control of BP or sugar, still you'll have this inflammatory process, and that cycle, that connection between all these things will always be prevalent, and patients might suffer the complications of diabetes even though they have a good control of sugars. So therapeutic strategies are of course there. The approved long-term use are orlistat, bupropion, and of course the GLP-1 receptor agonist at a higher dosage of 3 milligram, and of course the injectable semaglutide right now approved for non-diabetic obese also. And of course the newer medications, as we said, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists, all these things are nowadays available, which have weight losing property. So the approved long-term use, these pure weight reduction medicines, they do have their own side effects. So an anti-diabetic medication in a diabetic individual with a good lifestyle modification will definitely achieve a very good weight control, and it can act as an anti-obesity drug also. Of course, when we talk about the treatment of obesity, where the drugs which have a tendency or which have the property of reducing weight also have a property of reducing the incidence of heart failure. So you take a patient who is obese, and he comes in with a heart failure who is a diabetic, we could nowadays see a lot of heart failure with preserved ejection fraction patients, rather than they going into a vascular problem like a coronary artery disease. So these kind of newer drugs, anti-diabetic drugs like SGLT2 inhibitors, when they are being started in a diabetic individual at an early stage, we can prevent them from going into a diastolic dysfunction state or heart failure with preserved ejection fraction. So these drugs are very, very important, very, very useful in preventing them going for a heart failure. So always you have to choose the anti-diabetic drug, which not only has a glucose reducing property, but it also has a lot of pleiotropic effects, which is a cardiac safety beneficial. It should be renal safety and beneficial, and to an extent, which has a property of reducing the blood pressure, the lipids, overall, the patients going in for reducing the albuminuria. The overall, on a holistic approach of bringing down the all comorbid conditions of diabetic patients should be concentrated when we start the treatment of these patients. And this is where SGLT2 inhibitors, they play a very, very major role nowadays in our diabetic treatment. There are lots of evidences based study where the dapagliflozin or empagliflozin, everything has been studied. And this particular study to look into, it is a 24-week international multi-center randomized double-blind parallel group study where the HbA1c fasting plasma glucose significantly improved from baseline when the patients were put on dapagliflozin. And on top of it, not only that there was a glycemic control, there was also a very good reduction in the body weight, systolic blood pressure from baseline over 24 to 8 weeks respectively with dapagliflozin. So which means, as we said, when we choose a drug therapy for a patient who is diabetic, we should also concentrate on targeting the other comorbidities like lipids, BP, weight, everything, so that if they are also getting control, then the drug is a wonderful drug where we give a holistic approach in treating our diabetic patients. So with this, with these evidences, there has been a lot of drugs coming into the market, especially this SGLT2 and DP4 combination. And when we try to put our patients on both these drugs together, even they have completely different mechanism of action, but they are synergistic to each other. They have additive reduction in HbA1c. Not only that, they meet almost all the pathophysiological pathway in the ominous octet of pathogenesis of diabetes, type 2 diabetes mellitus. So if you look into the ominous octet pathophysiology of diabetes mellitus, if you use these two drugs in our patients, all the pathophysiology will be taken care of when we put the patients on these two drugs. And nowadays available in the combination therapy, there have been a lot of studies where these two drugs have been put together, and they give a very good effect with respect to glycemia, body weight, BP, lipids, and albuminuria and heart failure, and many aspects. So advantages of this combination is improves both insulin resistance and the functioning of beta cells. It is safe and it's rapid and sustained glycemic control is there. Something like sulfonylurea failure doesn't happen with these two drugs because it doesn't act much on the beta cells. Of course, DP4 inhibitors to an extent, but SGLT2 inhibitors are insulin or beta cell independent. Hence, at various spectrum of diabetic duration, these drugs can be used. It aids in the body weight and blood pressure reduction, and it is more patient compliant, reduces pill burden when we give it as a combination therapy, and of course it becomes cost effective because when we use this drug we can expect less complications in our populations, hence it becomes cost effective. So with this introduction, let's go to some kind of questions and discussions with sir. Let me end my lecture here and we'll go for the discussions.
Thank you, Dr. Varun, for a detailed discussion on obesity and its implication on development of diabetes and CVD diseases. We have a few questions for you. Uh, we all know that the root of obesity or the seedling starts in adolescence and or in the childhood. Uh, what implications does this have on future development of diabetes and its responsive disease?
Yeah, so there is a say that insulin resistance starts from the womb. Even in the fetal stage, the insulin resistance starts. And there is a lot of factors in the intranatal state and the postnatal state just after the baby is born, even within the first year of age, these kind of insulin resistance they start. So this postnatal food habits till the adolescent age matters a lot in bringing down or bringing up the obesity. And once the kids or childhood people, they start becoming obese, they are prone to get resistance towards insulin. Of course, there are these dietary habits which are a major problem. Of course, the genetic factor also, as I said, the South Asians, especially the Indians, they have a lot of predisposing genetic factors where they are prone to become obese, and they have tendency to develop more fat globules when they eat even a lesser quantity of fat. So, with this baseline problem with us, we have to concentrate on giving a proper diet and reducing the obesity at the childhood and adolescent level itself in order to prevent them from becoming a diabetic at the early stage itself. So once they start developing insulin resistance at the childhood adolescent stages itself, the legacy effect and the metabolic memory sets in. So once the metabolic memory and legacy effect they set in, it is very difficult for us to prevent the complications even after 10 to 15 years of onset of diabetes mellitus, because the memory has already been set in. Even though they have a good control of their sugars, in the later stages, they are prone to develop complications. And this is the major problem where we have to look into at early stage itself to bring down the obesity and insulin resistance, especially in the childhood and adolescent stage. Of course, lifestyle modification is going to be the major role where we have to advise them. The parental approach should be very, very, very important. Watching TV and sitting and eating should be definitely cut down. A lot of binge eating, junk foods are all available. So all these things, we have to look into, because this metabolic memory, the legacy effect with the genetic factors, and the tendency of us having insulin resistance at the early stage itself is becoming will become a big problem at the later stages of the life.
Thank you. Yeah. Thank you, Dr. Varun, for a detailed answer. Uh, how are psychological factors and socio-economic factors linked with the development of obesity? Any thoughts on those?
Yeah. So with respect to the psychological factors, see nowadays, there are a lot of competitive exams. The NEET coaching starts from fourth standard, fifth standard, fourth grade, fifth grade. The IAS coaching starts from fourth grade, fifth grade. So there are a lot of competitive exams and competitive mindset where these kids undergo, where the stress levels go up, and they are forced to sit and read, and their normal childhood enjoyment and all these things they are reduced, which finally leads to a less exercise or less playing area times. And nowadays there are a lot of gadgets in their hands, starting from PlayStations to video games and the mobiles, iPads. So they are stick to these kind of gadgets, and they are reduced in their physical activities outside. So these are, and next will be the sleep deprivation. So they have a lot of public exams and competitive exams. They sit till the night, 2 o'clock, 3 o'clock, even at younger stages, and they sit and read a lot for them. So sleep deprivation also occurs in these kind of childhood people. So these are all these psychological factors. So once they sit and read for a long time, they don't move around. It is almost like a sedentary lifestyle. They have all their fast foods, or they have some eatables sitting and eating when they sit and study. So and moreover, the tendency of taking a mobile and giving an order in the online delivery food stuffs make them easy in ordering whatever they want. So these are the many psychological factors where the kids are easily exposed to, so that they stop playing outside. They stop going for a physical activity outside, and they are stick to their gadgets and food. So this is one major psychological problem where our kids undergo, which will lead to the obesity, diabetes, and CVD in the later stages. So next will be this drug abuse. Nowadays, drugs getting more and more. The alcohol abuse, tobacco abuse, even at the adolescent ages, school times, late school times, or early college times, adolescent ages. So these kind of bad habits also predispose them to become obese and diabetic, which predisposes them to become a cardiovascular disease patient. So this stress, depression, and the food habits, parental, less discipline stuff. All these things play a major role in the psychological factor, which contribute to the obesity and the diabetes and CVD.
Yeah. Thank you, Dr. Varun. Uh, any role of lots of diets that we are hearing nowadays on WhatsApp, like once a day meal, intermittent fasting,
Yes.
diets, this diet. So, what do you think about these diets in
Yeah,
managing?
see, nowadays, as you said, the paleo diet, the intermittent fasting, and all have approached a lot because a lot of social marketing, social influencers sitting and talking whatever they want to, maybe it's right or not, regarding this kind of fasting. So once they become obese and they have this fat globules being developed, they multiply and they grow big. So even though they try to reduce their weight after becoming obese by these kind of activities like intermittent fasting a lot, they tend to gain even more weight because the number of fat globules are not going to reduce. It is just the size which is going to reduce. So once the fat globules multiply when they become obese and become big, the multiplication stops, but it does not, decrease. The number of fat globules does not decrease, only size reduces. So again, if they start binge eating even at a lesser extent, they tend to put on more weight or double the weight what they were before. So these kind of drastic weight reduction makes them eat a little more excess so that they put on a lot of weight, which causes another problem. Second problem is, of course, these hormonal changes, the leptin and ghrelin levels, when we go with the intermittent fasting and long time fasting, when they don't eat anything for a month and then they start eating something, this leptin ghrelin hormones, they also act in a very bad way. So the leptin goes down and ghrelin goes immediately very high. They become very hungry, they eat a lot, and finally they'll end up in becoming more obese than what they were before starting their diets. So these crash fasting or crash dieting is not much helpful, and the slow lifestyle modification like going for a walk or giving a physical activity and slow changeover from the diet from a simple carbohydrate to the complex carbohydrate diet, reducing the binge eating, all these things will only help like our olden days. And now new concepts, of course, they will reduce their weight in the near future, but later on that might not be helpful in the longer run.
So yeah, you're absolutely right in regarding that. So there was a study where the patients were divided into three groups, and one of the group was advised intermittent fasting, another was the normal diet that they were taking, but these were equi-calorie diet. So both the groups were given equal amount of calories. So in both the groups, weight loss was equivalent. So it is not the timing that you are eating that is important, but it is the total amount of calories that you are eating is
Yeah, that
important.
is more important. Yes.
Problem especially becomes more problematic in people who have mild subclinical coronary artery disease. If they develop hypoglycemic episodes on these kinds of diets, then this will increase CV mortality in those patients. So it's not like it can be advised to everyone. The patient has to be screened by a um, uh, a medical caregiver before the patient starts himself or herself. So it is important that the patient first knows about himself rather than just starting on these diets.
Yes.
Uh, any guidelines on screening? How when the screening should be started? What way should we screen?
Yeah, see, of course, the above, more than 4 to 5, as I said, insulin resistance starts from the womb itself. The way if you say that the BMI starts increasing, then that is where we have to keep on checking their BMI levels every year. Annually, they used to say annually check on the BMI levels and check on their waist hip ratio. The waist hip ratio is very very important in assessing their obesity levels. And of course, there are if you want to go into more extensive testing, you can go for HOMA IR testing, checking for the insulin resistance. You can do a fibro scan to check into the fatty liver to know whether the visceral fat accumulation is more. And of course, go for other, if the patient parents are diabetic at an early stage itself, from the young age itself, initially can straight away start on, I mean, go for a GTT and check their HbA1c levels. If they become diabetic, going for an ECG, echo, and cardiac marker. So this way you can keep on screening them at what stage they are. If they are obese alone, check their BMI and check their waist tip ratio. Almost annually should be fine, and keep a track on it so that it doesn't go high.
Yeah. Thank you, Dr. Varun. You talked about pharmacotherapy, role of newer medications, especially GLP-1 and SGLT2 inhibitors in management of the twin problems of obesity, diabetes, and their impact on CVD disease.
So as our previous slides also said, there are a lot of short-term and long-term use of the anti-obesity drugs. But these anti-obesity drugs, they cause a lot of side effects like steatosis and other malnutrition sort of things. And these side even the psychological disturbances when we use the SSRI stuff. So the direct weight reduction drugs have a lot of side effects. So instead, we can use the newer therapy, especially the anti-diabetic therapy, which have a very vast exposure or very vast evidences of bringing down the weight. For example, this GLP-1 receptor agonist. So initially, in abroad, even in non-diabetic patients, they are using liraglutide and the injectable semaglutide, where they have very good property of weight reduction. Not only that, the GLP-1 receptor agonists are prone to have many other pleiotropic effects, starting from cognitive function to the cardiac contractility, bringing down the atherosclerosis, giving a renal protection. So these kind of lot of properties are there with GLP-1 receptor agonists. And along with that, when the patients are diabetic, usage of SGLT2 inhibitors, they do promote a lot of weight reduction when we use SGLT2 inhibitors. And these drugs have been marked a lot, and they are into the top line in the guidelines in American Diabetes guidelines and European Association, RSSDA, everywhere, where the patient, if the patient is obese, you can straight away start the patients on these two drugs, GLP-1 receptor agonist and SGLT2 inhibitors. Of course, GLP-4 inhibitors are weight neutral. They might not cause a lot of weight loss, but they are weight neutral. They are definitely not having any kind of weight gaining property. At the end, if the patient is morbidly obese, bariatric surgery, they do have a lot of evidences in reducing the insulin resistance, reducing the cardiovascular mortality, reducing the obstructive sleep apnea disease. A lot of anti-inflammatory properties are also there in bariatric surgeries, and in morbid obesity patients, you can go with bariatric surgeries also. So this way, we can manage the obesity in our diabetic and cardiovascular disease patients.
Thank you, Dr. Varun. You actually answered my knee in my next three questions as well about the combination of DPP4 and dapagliflozin. So you actually answered that also. My last question to you is, I believe the most important part in managing these patients is counseling. How to go about counseling in these patients?
Yeah, usually what I do is I spend some time with my patients. I sit with them. I discuss with them what their ASCVD risk factor is, what obesity is, what the pathophysiology of diabetes is. Because without patients understanding what the disease and what it does to them, it is hard for us to make them come into the track and other to the treatment. So when I start on some therapy, they should be aware of that this drug is going to do a lot of positive effects for their kidneys and heart and obesity also. So that with this, we can make our patients become more adherent and more regular with these therapies. So instead of starting a sulfonylurea, which is freely available anywhere, or which is whether if it is cheaply available, even that also brings down the sugars. But the other pleiotropic effects, which are very, very important in managing the diabetic population, especially in the elderly people and longer duration of diabetes, these kind of combinations of dapagliflozin and sitagliptin are going to be a very positive effect. They give a positive effect in our patients, and they will have a very good quality of life. Just living is not important. Living healthy is very important. So it gives a very good quality of life, and also it gives a good mental peace for them, so that they are not running into the hospital for other comorbid conditions. They are way back at home just to visit the hospital every 3 months just to check their sugars and get their medications done. So these kind of comfort living should be explained to them, counseled to them properly, either by us or by the health educators in our hospital or the dietitians in our hospital, or through many awareness videos which we can put should be authenticated. These videos should be authenticated, not just like that, talking about by the social influencers. No? So these kind of approaches and counseling can be done to the patients. You can run through some videos when they are waiting in the waiting hall, addressing the pathophysiology of fatty liver or cardiovascular disease, so that they can understand what these are and what we are aiming to give them these drugs for, and they should understand these things. So once this is done, I think counseling becomes quite easy.
Yeah. So, thank you, Dr. Varun, for a very nice presentation today on obesity, and you talked in detail about how obesity affects the chances of developing diabetes and then CV disease and mortality as well. We discussed about the psychological factors. We discussed about the socio-economic factors that increases the risk of developing obesity and problems. You rightly talked about the role of physical activity during childhood and adolescence, where the actual problem begins. And if we are able to take care of our children, if we are able to make them physically active, probably the problem becomes much less in the adulthood. So, thank you, Dr. Prasanna,
Thank you, sir.
for
Thank you,
very
sir.
interesting. Thanks a lot. Now I'll hand over the session to the
Nice session to chat and talk with you. Thank you, sir. Thank you.